All right, good afternoon, everyone. Thanks again for joining us today on the third installation of the Region 5 Infant Mortality webinar series. My name is Lynn. I'm one of the staff members at CityMatCH. And today I'm really excited to feature Dr. Vijaya Hogan on our webinar. And Dr. Hogan is a nationally known perinatal epidemiologist. She was a member of the DHHS Secretary's Advisory Committee on Infant Mortality, also known as SACIM, and she has served as a program officer at the Kellogg Foundation. She was a professor in the Department of Maternal Child Health at the Gillings School of Public Health at UNC-Chapel Hill. And she was the lead epidemiologist on the Preterm Delivery Research Group at the CDC. In her career, she has worked at the community, state, and federal levels, in public and private sector, and in several and in academia, and has worked with both domestically and globally. She conducted research and authored several papers related to the understanding and addressing of health inequities in perinatal outcomes. She currently is an independent consultant and utilizes her expertise to build the capacity of MCH and other public health organizations in their implementation of strategies to effectively attain health equity. And just before we get started, I just wanted to say that the Q&A function is there for you to use. If you have any questions or anything throughout her presentation, feel free to submit them through that Q&A box, and then I'll open up the chat at the end, and we can have some time for discussion after Dr. Hogan's presentation. And with that, Dr. Hogan, I'll pass it to you to get us started.
Thank you, and welcome everybody. Thank you for inviting me to work with Region 5. I'm just going to share screen here. And let's see. Okay, can you see this?
Yes, we can.
Okay. You can see. Okay, great. So let's get started because there's a lot to cover, and I want to make sure we have enough time at the end for discussion. If there are clarification questions along the way, you could put it in the question box, but otherwise it'd be best if you write your questions or comments down, and then we can share it during the discussion period at the end. So today's topic is called Achieving Equity in Infant and Maternal Morbidity and Mortality, Disrupting the Status Quo. What I would like to happen by the end of this session, it's actually 2 sessions. This is the first of 2 sessions. At the end of the second session, I would like for you all to be able to embrace a conceptualization of racial equity as a complex outcome. And what that requires is the second objective, which is that you're able to disrupt the current ways that we think about how to address equity and that are currently miring our public health action in old ways that don't necessarily function to achieve equity. And thirdly, to enable you to establish a more systematic process, structure, and appropriate funding and oversight for building the capacity to achieve equity. It's a tall order. So what I'm going to do today in this first part is I'll first recap the problem of inequities, and basically I'm just going to quickly review some of the key points that Dr. Warner and Dr. James presented in the last session. Then we'll go through some current approaches to achieving equity with a critique of where they fit in the process. What are some of the challenges that these approaches present for being successful in addressing equity? So we'll talk about some of the strengths and limitations, and then I'll provide a little bit of an introduction to what we need to change to effectively address equity in preparation for part 2, where I'll go into more detail about that. But this first session is really critical because it's really difficult to build something new until you've been able to disassemble the old. And to be able to do that, you have to understand what the current approach is and where the strengths and limitations are so that we know what needs to be changed. And I will leave time at the end for discussion. Okay. Okay, so while the focus of this presentation is on Region 5, the same challenges will face all other HHS regions, and it will not only demand changes in how Title V agencies should do business, but also how funders, how our partners, how the other aspects of the federal government do business. So this is relative to everybody. I'm not sure why this thing is moving by itself, but okay. So let's start. So in the early 90s, that's where this picture is from. I was a part of a small group of epidemiologists at the CDC. And this group started the research in the United States on the effects of racism on preterm birth. I'm sure there's some people on this call who were part of that work group. Now, this work spawned a whole new generation of researchers, new directions in maternal child health and across health in general. It also initiated the use and acceptance of qualitative methods, of storytelling, of community partnered collaborations, in addition to generating a new body of research on the impacts of racism on health. It also turned the lens to focus more on social determinants of health and equity. Can you still see my slides?
Yes, we can see your slide.
Okay, all right. Sorry, couldn't tell. Okay, so my reasons for bringing this up is twofold. First, this was the work of a small group in the Division of Reproductive Health at CDC, and it included individuals from various other divisions who formed a work group. It wasn't necessarily sanctioned or embraced by the CDC as a whole, and one could not have called CDC an anti-racism organization because of the work of this one group. It really was a struggle at that time to get this agenda moving within that organization because of a lack of broad institutional awareness and support. And it was a struggle to obtain some of the institutional changes and some of the resources that we really needed to support the qualitative and community engaged work in communities. We had what I would call an equity implementation zone within a larger organization. And we had that difficult task of transforming that entire organization and all of government and research in the process. But I want to repeat, that was 30 years ago, a whole generation. There is a lot to show in terms of the trainings that have developed since then, the research conducted, articles published, diversity that was embraced, et cetera. But we don't have a lot to show in terms of equity outcomes. Dr. James' data showed very clearly in the data that we haven't made much progress on equity. And I say it again, this was 30 years ago. We have not made progress. And it was just this month, April 2021, that CDC as an organization publicly declared racism as a public health crisis. It took 30 years for that to happen. So this is a wake-up call for all of us that we really need to revisit our approaches and really critically analyze them in the light of the problem at hand and change course now to meet the moment. I'm sure you share the same sentiment that I have, that I don't want to wake up 30 years from now still talking about our will and our need to achieve equity. It's really time now to turn that corner and find the transformative approaches that are going to get us to that outcome. So we can't ascribe the work of one group to a whole organization. We cannot wait another generation for progress to happen. And we need for you all to make it your leadership legacy to achieve actual and sustained progress towards equity. And that takes a few things that are going to be different from what we're used to right now. So first, I'll start with the recap of the challenges of inequities in maternal and child health. And again, I want to thank Drs. James and Warney for their slides. So first, Dr. James presented extensive data on the challenges of disparities in infant mortality. We could do the same for prematurity, for maternal morbidity and mortality, and we probably see similar trends. The overall rates of infant mortality are declining, but the disparity is not. We see this in Ohio in this data that's presented. Sorry. And I believe there's evidence that there are different things that need to be done to achieve equity above and beyond the things that we do to achieve the reduced rates. Dr. James showed the trends over time are persistent across all of the Region 5 states. He also demonstrated with data the higher rate of improvement of infant mortality for white versus Black infants, and because of this, an actual widening of the gap. And again, this is consistent across all the Title V states. The white rate is improving at a much faster rate than the Black infant mortality. And finally, Dr. James presented data showing the amount of catch-up time that's required for Black infants to reach the rate of white infants. In any index year, it takes 34 to 45 years for Black infants to reach the rate of white infants. So inequities have persisted over time and over place across Region 5. Inequities have complex causality, and that's something that I think we have to embrace. They have dimension that we haven't really addressed and that is not responding to our current attempts to lower the rates. And so that's something that we have to address head on. So Dr. Warner gave us some insight into this, why it's so intractable. And he talked about he sort of presented the origin story of disparities specific to Indigenous people. And he talked about a history that included genocide, historical trauma, excuse me, displacement, cultural stripping. And this is important to understand. This past oppression has an impact on the present outcomes. And these past oppressions have epigenetic impacts that get embodied. They have social impacts that limit social, environmental, and economic opportunities of whole groups of people. And all of these create stressors that can affect behaviors and health in general. Then Dr. James painted a similar picture of the origin story of inequities by reminding us that 60% of the time of African descended people in this country was served as enslaved beings, 25% under apartheid conditions, and 15% of the time where there's supposedly free and equality. We still see people of color being arrested, sentenced, jailed, killed, undereducated, denied access to jobs, real estate, et cetera, earn lower wages compared to whites over this period of time. So the point here is that reckoning with our past is not a discussion activity. It is absolutely critical to undo the damage of the past and level the playing field, because when you see these disparities in health today that we just saw in that data, it exists precisely because we have not repaired the damage inflicted on populations of color in the past. If you can imagine a relay race that's actually a marathon, and you imagine after one round, you get all kinds of assets that you get to pass on to your next generation. And this goes on and on and on for generations. And further imagine that one group of people are systematically forbidden from even entering that race for, let's say, 200 years. And then after that period of time, people say, oh, this isn't fair. Everybody should be allowed to participate in this race. And so everybody gets allowed to enter the race, and the race starts, and you can immediately freeze frame. And what you're gonna see is one group way ahead, another group way behind, because of that historical oppression. And if you haven't done anything to undo that damage and close that gap, then as the race continues, it's just going to continue to maintain that disparity over time. So this is what we're facing today. This is why we see disparities today, because they've existed in the past and we haven't done anything to undo them. And so that's one of the challenges that we face in addressing disparities, which is to undo some of the damage of the past. So when we look at the causes of disparities from the research, we see multiple avenues of causes. We may institute strategies to address one or two of them. We often don't go as deep as we need to address any of them. And so we end up with the lack of change in the rates that we're seeing today. So in fact, inequities are very complex, and I don't think that as a whole in health and in public health that we really appreciate the complexity of it. Health inequities and racial equities, for one, are intricately tied to one another in a really complex web of factors. There's so many contributors to health inequities that cover time, space, institutions, and it's not an easy thing to unravel. So this picture, I think, is, to me, a good way to convey the complexity of health inequities. This is actually some river. It's a topographical map of a river somewhere. I'm not even sure what river it is. But it just seemed to be such a good description of it. So we have this big river of disparities that's actually fed by all of these tributaries that roll and feed into the larger river. And that is, a lot of us. We each have some control over small aspects maybe of one of these tributaries, but there are all these others that are still feeding in the river. So even if we're successful in our little piece, it doesn't necessarily change a whole lot in that big river of disparities. And that's why we don't see things changing with the rates, which means we need to step back and think about different ways of approaching how we address disparities. And I know, understanding and accepting the complexity of the problem makes people feel like it's impossible to deal with. But I can tell you, and you all have experienced, that mankind has tackled much more complex tasks than this. So we have to acknowledge and become intent on unraveling this complexity. And as I mentioned before, that will include undoing the damage that was done in the past. Then Dr. James asked some really compelling questions, I think all of which point to the challenges we have to reckon with to get to equity. In fact, if your approach answers and addresses these questions, then you probably are on the right track in terms of reaching equity or on the road to reaching equity. But if not, then we have work to do. So these questions include, what does this history and its present day effects mean for action to produce equity? How do we repair the effects of such an adverse history so that we can achieve equity? How do we speed the improvement in the Black rate so as to get to parity and silence voices who think it's okay to speed progress for white babies, but not babies of color? 3, how do we correct the imbalance that white privilege creates? And 4, how do we become anti-racist in a climate where some people are emerging in their understanding of its existence and virulence, while others are retrenching within white supremacy? Excuse me. So the bottom line and the thesis of this presentation is that the problem of inequities are the epitome of what we call a big, hairy problem. These are things that are really complex and really difficult to address. But the approaches that we currently use are inadequate to the task. They're essentially like trying to bail out the ocean with a teaspoon. The causes and the cures for inequities in maternal and infant health are so much more complex than the methods we employ to address them. And so the challenge we have is to bring some alignment to that relationship. Excuse me. So let's move on and take a critical look at how we're currently addressing inequities in health. So this is an incomplete list, but all of them are processes that I've observed across many organizations over the past 10 to 15 years. My colleagues and I actually conducted a qualitative study of Kellogg-funded breastfeeding programs to assess how they're addressing equity because Kellogg Foundation at the time required that equity be a part of every grant, but they didn't provide any guidance as to how that should look. So many of these approaches that I'm going to describe come from that study and many other observations and interactions since then. So as I go through the list, I'm going to go through each one, but I want you to see if you can find your own organization in one or more of these categories. Excuse me. But I do want to make sure people understand that what I'm going to describe is sort of the worst case scenario within each one, and there are many variations within them. That's number one. Number two is that there is no judgment involved in any of this. I think the whole point is for us to really understand where we fit, to be able to describe what it is that we're doing to address disparities in a coherent way so that we can move past it and do better. So the first one is doing nothing. So again, no judgment, but I think we again need to be able to articulate how we're addressing equity. And as I said earlier, inequities are really complex and many people just don't know what to do. And excuse me, sorry, the pollen is bad today. As I mentioned earlier, inequities are very complex. Many people don't know what to do, but we in academia have to take some blame here because we have not done a good job in either agreeing on or presenting a roadmap for what a holistic and coherent approach is to achieving equity. And so it's sort of been every person for themselves. So in this category, there are people who just don't know what to do, and that's totally understandable. There are also within this category some people who think they are working towards equity, but in actuality, they aren't doing anything really concrete. They might know all the right things to say, the right things to write, the right boxes to check off, but they're really not doing work with the rigor and intensity that is needed to achieve the outcomes. And then there are other organizations with leadership who are totally ignorant, either intentionally or unintentionally, of the problem of inequities, and therefore don't prioritize it. It becomes something that's separate from public health rigor, which is not right. And so it becomes a lower priority. Still others in this group are aware that inequities are a problem, but again, they've decided that it's not a priority for them. And there are those who understand the urgency, but they find that it's just too hard to do. And they try, the challenge pushes back on them, and they end up giving up. And then there are a few in this group who believe that they've done all that there is to do and there's nothing left. They've done their implicit bias training or whatever their approach has been, and they're done. There's nothing more to be done. So, this doesn't describe your agency. Think about whether it describes anybody in your community who has impact on the lives of populations of color and low-income populations. If it does describe any of them, and they are in the preponderance of organizations, then you should understand why disparities still exist. Building equity is not a one-person job. It's not a one-agency job. It's not a temporary project. It requires all hands on deck. The next prominent approach I call equity after the fact. And this probably describes about 90% of anybody who's working on equity. In this approach, equity is usually an afterthought. The program or intervention or policy is planned, funded, and then you think about how to add equity. It's sort of like, I don't know if you've seen these recipes where there are all these steps, and in the end they say add salt to taste. It seems as though there's a belief that equity is easily added on at the end as just something to spice up what we already designed. But in fact, it's nearly impossible to be rigorous in promoting equity when 90% of the decisions have already been made. Equity needs to be integrated from the beginning, and it, excuse me, I'm so sorry about this. And it needs to operate sort of like DNA. It's a script of instructions that guide along the way. So in this picture, it should happen at this beginning stage of planning and not towards the end when the house is already built. By then, there's no way people are going to turn back and undo some things that are pretty major in order to fit equity in. So after the fact doesn't work very well when it comes to equity. Another approach I call DEI outsourcing, diversity, equity, and inclusion outsourcing. Excuse me, in the worst case scenario in this approach, organizations basically select someone to lead their equity efforts. They toss them the responsibility and maybe forget about them. They're usually underfunded, under-resourced, lack power to change anything, and lack power to change how the organization as a whole does business, which is necessary to achieve equity. Another manifestation of this is like I described earlier at CDC. There may be self-identified equity champions within the organization who are doing the work in their limited realm of influence, but the organization as a whole takes credit for doing equity work because of the work of a small team. They might cite it in grants or check it off in an accreditation review, but it's just one small group of activity and not the whole organization that's actually doing the work. Outsourcing also manifests as an assumption that if a person of color is leading an initiative, well, of course, they'll take care of equity. In fact, all people of color do not have the capacity by virtue of their skin color to implement what's needed to achieve equity. Equity is a science that needs to be learned like any other science. And most of us have not been trained in that. And that can work both ways. You might have people of color who assume because they can relate to populations that they understand the science of equity implementation. But again, most of us have not been trained in this. The next group is called cherry picking. And basically, in this approach, an organization just ignores the parts of equity that they're not comfortable with. I don't know, how do I get this thing from changing by itself? Because these slides seem to have a mind of their own. But anyway, all right. So in this group, we have decision-making processes that default to easy choices without regard for their impact on people of color or on inequities. It manifests on relying on the practice of addressing the low-hanging fruit or making decisions based on feasibility, all of which sort of skim the surface and never get to the depth needed to address disparities or close the gap. Remember, inequities are a complex problem, so always reaching for the low-hanging fruit is not necessarily going to get it. And this is yet, a very prominent decision-making tool that we use. So this is just sort of that feasibility decision matrix, feasibility impact matrix, where you have in quadrant A, the things that are easy to do and have very high impact. So let's say we're talking about equity. Those are a no-brainer, those things we want to do. But then there are some things that are easy to do, but don't have very high impact. Those are some of the low-hanging fruit we end up doing because chances are there are very few things that naturally fall in column A. There are probably more that fall in column C. And we spend a lot of time doing some of those things that aren't necessarily getting us very far in terms of addressing equity. In fact, most of the things that relate to this very complex outcome fall in column B. And yet these are the things that we're most likely to put off for some time in the future that we never get to, or we kind of sweep it under the rug because it's too hard and we don't have the resources to break it down and to attack it. And so, again, we perpetuate the problem because we're not addressing it directly. But this column B really describes inequity. They're really difficult to do long-term solutions, and they can't continue to be systematically ignored. Okay, this one is my personal favorite. I call it the road to Canada approach to cherry picking. Now, in this manifestation, let's say you tell your supervisor that you have to get to Canada to save your life or to save somebody's life. And your supervisor says, oh, yes, I fully stand with you and I support you in you getting to Canada. Go, be on your way, do what you need to do. Oh, by the way, you can't travel north. So, if you're in Michigan, maybe that's okay because you can go east. Or if you're Elon Musk, you could send a rocket into space and time the arc to come down over Canada or something like that. But that's a lot of effort that is kind of ridiculous. But the proviso that you can't go north effectively undermines your ability to ever get to Canada. So how does this relate to equity? Well, we can refuse, for example, to focus on the issue of racism. I mean, how many times have you heard people say, we stand with people of color, we want to eliminate disparities, but we shouldn't talk about racism, or we don't need to address racism, or we're not racist, or there's no racism happening here. This is a big problem, and this is something that affects many institutions that hold the power to really create structural change and social change in our communities. We can't continue to brush the issue of racism under the rug because this is the main vehicle that's going to get us to Canada. It's going to get us to that point of undoing racism and addressing inequities. The next one is training, which is probably the latest trend in addressing equity that's, really picked up in the past 5 or so years. This is a very incomplete list of the available trainings that relate to equity that people have participated in. I'm sure there are plenty more, I just couldn't fit them on the page. But even with this list, this partial list, within each category, there's a wide distribution of quality, of content, and of impact of these trainings. So there's no standardization anywhere. So it's hard to know what you're getting until you've actually gone through the training itself. People invest in training because they recognize that something needs to change and they want to learn something new. It's just that in the realm of equity, we often don't know specifically what is the piece that we need to know now to move to the next level. And so we end up sort of running around getting trainings and, putting them in our pocket and not knowing what to do with it. So don't get me wrong, this is a really powerful tool when it's a part of a broader capacity building development process. But the research is pretty clear that information sharing and sort of low-level training doesn't change how things are done in the long term. And you could look at the data on implicit bias as a case in point. This is the newest rage in public health and in health in general. And yet the research shows that it doesn't result in lasting behavioral or structural change. It does improve awareness. It's very good at doing that, but it doesn't last over time, and no changes in how processes and procedures and rules change to promote or inhibit equity. So that's not to say don't do it. I'm just saying that it shouldn't be a one and done approach. The other aspect of training, the other limitation is that if it increases capacity and achieves the bolded outcomes on this slide, it's very critical to achieving equity. However, we have a tendency in public health to sort of skim the surface, to take the easiest path, and we end up not going deep enough to reach the meat of the problem that we're trying to address. So to the extent that trainings talk to people, provide information, but develop no capacity to create and sustain change, it's not a resource that's well spent. We really need to up the game here and make these trainings part of a broader and systematic capacity building process that's going to create the ability to, and the systems to promote and sustain equity. Finally, this is where I think we should all strive for, and this is the approach of integrating equity into the DNA of your organization so that all processes, procedures, rules, policies, decisions happen through an equity frame. You might think that equity intervention should be aimed at changing community behavior as opposed to organizational behavior, but I remind you that organizations collectively make up society. And if we want to achieve social change in the end, we need to start by transforming each one of our organizations and how we do business so that each one lives and breathes equity, excuse me, and is able to create the conditions for promoting equity. So social change is necessary to achieve equity. I think we all understand that. Societies change when the organizations within it and the institutions within it change. But those organizations and institutions only change when they transform aspects of their own culture, processes, priorities, resource allocation, relationships, power sharing, et cetera. So it's achieving equity is not necessarily about starting out doing something in a community. It's changing the DNA of your organization so that when you do those outward facing activities, it's done in a way that's really going to make a difference and have an impact on those equity outcomes. So we have to learn to live and breathe equity and continuously create those conditions for equity. And you have to be willing to resource them appropriately. So that's just a summary of some of the approaches that people take to equity. So I'm going to go a little bit deeper. So one of the things that I remember in my very early public health career, one of my mentors, Earl Siegel, used to say, you know, maternal and child health is all about doing the right things and doing them right. Well, since then, I've really learned that there's a lot more nuance to it, especially when it comes to equity. So equity actually requires doing the right things, doing all of the right things. So again, complex outcome, multiple causes requiring multiple lines of attack. We can't choose one and expect to have an impact. Remember, all of those tributaries, we have to address all of the factors simultaneously. And we have to do them right. So that means science-based, respectful, coherent, matching the needs of the people we're trying to work with, and doing the right things and doing them right for everyone. So it doesn't work when we have one community over here who we're doing all the right things for, but a community over here where we're not. So we have to do the right things for everybody and do it right for everybody. And that requires that we have the capacity to know what those right things are, and then to know how to build and implement them in ways that are going to address the needs in communities. Now, all of this is actually doing robust public health. So, you know, we often think we're doing really good public health, but we just sort of skim the surface. Another aspect that we kind of get wrong with equity is we assume that all we have to do is apply evidence-based practice to populations who are experiencing disparities, and then we'll achieve equity. And, you know, this is not enough. It's necessary, but not sufficient by itself to achieve equity. It may help some people who are sort of on the borders of vulnerability, but the vast majority of the populations who experience inequities are not going to be impacted by just evidence-based practice. Another mistake that we often make is to conflate social determinants of health with addressing equity. Again, necessary, but insufficient by itself to achieve equity. When we address social determinants, we often do it from an individual level. So using case managers or doulas or some other type of community health aid, while it's important in their effective personnel, they also still address social determinants of health from an individual level, person by person. They don't necessarily change the production of risk exposure for future population members. Sorry. This is a Band-Aid, it's remediation. It's not necessarily structural change. Now, there are some again, who may work a little bit more upstream and do actually change the conditions in communities. Again, and that's what we're striving for, but it has to be across the board. So every population who experiences disparity should have access to that changed environment. The other thing to understand is that it's very clear to do the right thing, but do it wrong and actually exacerbate disparities. So, you know, we can address social determinants of health and make some communities more livable, more walkable, less lead, more supermarkets, et cetera. But if it's not done through an equity lens, then you can end up creating worse disparities by enhancing gentrification or displacement, et cetera. So again, social determinants are necessary, but by themselves, they're not the cure-all to health inequities. And I've been mentioning a couple of times that we're not doing robust public health. And doing good and robust public health is absolutely necessary to achieve equity. If we don't have robust public health, we're never going to have equity. No chance. So, for example, when we do something like place-based work, there's a spectrum to this. At the lower end, there's where we place an intervention, we design the intervention and then locate it in a community. At the more intensive end is where we create a holistic plan for changing community conditions so that we stop production of risk and level the playing field for people who experience disparities. Our propensity is to work at that lower level and chase after the low-hanging fruit. So what that means is we look for opportunities that present themselves, and we sort of cobble together this picture of health services within a community that may or may not work for the people in that community. So take a look at this picture, for example. So if you first look at it, it's kind of pretty, actually. It's pretty beautiful. All the pieces fit together perfectly. It's colorful. It has recognizable components. But if you look closer, you'll see that it's completely incoherent. Who is stepping back to look at and monitor the big picture of public health to ensure that there is coherence in all of these pieces that we've sort of cobbled together from the perspective of the people who have to live in these communities and utilize services, et cetera. So this is what public health might look like from people in the community. Again, the interventions may make sense to us, but they don't always make sense with respect to someone's lived lives. So how this usually manifests is we have interventions or programs scattered across communities that may address social determinants at the individual level. And these allow public health agencies to check off a box. But number one, all the needy communities may not have access to the same. All the people in communities may not have access to it. And some of the upstream factors that allow the downstream interventions to actually be fulfilled are not necessarily in place. So what results is an incoherent picture of public health from the perspective of people who have to use the services. So just to go into that a little bit further, we're all familiar with the social ecological model. And we often design individual solutions to social determinants of health, and that's fine. So let's take doulas or peer counselors, for example, who we hire to help address individual social determinants of health. But if we don't also simultaneously address those upstream factors that will change the conditions and stop the production of risk, then we're sort of undoing what we're trying to do. You know, the risk is going to keep being produced. There are always going to be more people who are experiencing these risks. And so you need more and more peer counselors or whatever to address those risks. And so the wiser thing, which we understand as public health, is to change the conditions in these upstream levels that relate on each level that facilitate or enable you to have more impact on the individual level by changing some of the upstream factors. And so coherence means making sure that when we design an intervention at one level, let's say our focus is at the lower level, the individual level, we also have to look upstream and see what do we need to change structurally at these levels to stop that production of risk so that we're not constantly dealing with individual by individual change. So again, doing robust public health requires working upstream. So just to summarize, our current approaches to addressing equity do not necessarily consider all aspects of the complexity of the problem. They're rarely holistic, they're often cherry-picked piecemeal, and in some cases, somewhat incoherent in terms of the lives of people. And what that means in some aspects is that it actually can cause more harm or more stress to the people who are receiving the services. So yes, it is possible to receive a social good, but it actually is harmful. Our approaches rarely go deep enough to make a dent, which is evident in the outcomes that we see in the data. They're often under-resourced maybe because we don't appreciate the complexity of the problem and assume that simple solutions are enough to address it. But again, the data shows us that that's not the case. Most of them are not systematically planned. They're usually opportunistic. Something comes along, funding or funder is supporting something, or the government has a grant out. And so we use that to sort of cobble together some things that we need, but we're not really working towards some bigger picture that's coherent and that makes sense. We're not building towards that. Our efforts rarely are sustained, and they don't create consistent reductions in inequities. And the last thing is we often assume that equity exists somewhere out there rather than turning the lens on ourselves, our organizational processes, our decisions, our own personal ways of thinking and mindsets to see where we can change to create that sort of synergy of change. So the question is, how do we approach the achievement of equity? Most of that we're going to delve into in the next session, but we'll just sort of lay the foundation for it here. And we're all familiar with this illustration of the difference between equity and equality. The reality is actually somewhat different because of history that Dr. Morney and Dr. James talked about so well, some populations are in the equivalent of this hole or deficit. And some people have privilege beyond measure. And so trying to address that, if you just sort of think about and imagine what it will take to address that situation, you could see that it's mismatched with some of the approaches that we're taking right now. And I always thought that the baseball game is not really the greatest metaphor for this image. So if you can imagine instead that this was school or a healthcare system, then the consequences of not doing anything or the consequences of the things that we do make a bigger difference. So you can imagine all of the things that would be necessary to get the first kid in the purple shirt out of the hole, what it would take to repair that hole, what it takes to find a place for him while the hole is being repaired. There's one space available, and so we can't place him there. Who gets to choose? How do you choose who goes where? Who gets the open space? I mean, there are a lot of difficult decisions to make. How do you convince the person who's extremely privileged to give up some of that resource to support everybody else, to redistribute, or whatever you need to do to get to equity? And you need to collaborate across sectors because we in health we're not construction workers, for example, so we might not know how to build out that hole or to whatever. So it takes a lot of effort just looking at this diagram to figure out what we need to do to get to that the last two boxes in equity. And if we compare that to some of our approaches right now, we could see that we're not getting there. They're a big mismatch. The problem and the solution don't get to the point. So what do we need to achieve equity? We need to remediate existing risks. So that means addressing medical risks, social determinants, et cetera. And that's something that we do really well in public health. I think, we're very good at that. And that's what we've unfortunately where we've put all of our eggs. We also need to actively remove racism where it exists. Where we have control is within ourselves, within our teams, within our organizations, and within our networks. We have some power to change how those processes proceed so that they don't produce inequitable outcomes. And so we need to be actively engaged in that process of removing racism. We need to repair the historical and intergenerational damage that was done by the experience of oppression and all of its minions. This is not something that we could just skip over because, again, think back to that relay race. If you don't repair the damage of the past, then we're always going to have that gap in between groups. And we need to restructure. So that means to eliminate the sources of risk, stopping the production of new risks so that next generations of participants are not experiencing the same thing. We're restructuring communities, institutions, et cetera, so that we're not constantly producing more risk. And it requires what I call provide, which is essentially an implementation process. And that's what doing the right things right means. It means we might define the evidence-based practice, but we have to get it right in the community. We have to match it to the life, the resources, the timing, et cetera, that works in the community. And that's what provide and implementation efficiency means. So this is part of the model, which I'll talk about a little bit more, an equity framework, which I'll talk about a little bit more in the next session. But this is the bare minimum of what needs to happen to address disparities. So whenever we have an equity plan, it has to include components of all of these things. So the next session, we'll get into that a little bit more, actually a lot more. So I realized that this time I spent a lot of time sort of deconstructing the ways we think about and approach equity. I really need you to continue the work thinking about and inquiring within your organization about how you're actually approaching equity and if any of these descriptors fit you. This is really important because, as I mentioned before, you can't build something transformative until you're able to sort of deconstruct the status quo that we know is not yielding results. And you have to be able to describe what you're doing now. One of the things I've had a really hard time getting organizations to do is to describe what their equity approach is. People cannot articulate it. And when they do, they're often describing things that they're doing. They're doing X, Y, and Z. They're incorporating community and they're addressing social determinants in some community, but it's things that they're doing as opposed to things that they're building. And I think that's an important distinction. If all you can describe is what you're doing and you can't describe what you're building in that doing, then my question to you is, how do you know down the line that it's going to pay off? Excuse me, if we have to wait 30 years potentially to see changes in outcome, how do we know today that we're on track for that improvement down the line? are you all certain that what you're doing today in 25 or 30 years is going to end up in equity? So that's something to think about, and think about the questions that Dr. James raised earlier as well. To what extent is what you're doing addressing those questions? So, you know, we really have to deconstruct that and start over with something that we know has a greater chance of being effective. And we need ways to monitor and evaluate the process to ensure that we're going to get to those outcomes down the line in the future. And I don't know if it will take 30 years if we're working appropriately with the right tools and the right structures. I'm hoping it's going to be a lot less time, but we have to know now, and we have to be able to monitor the process. It's the process that's important, because the outcome is going to take a while to unfold. But we have to be sure today that the process is right, so that we're reasonably certain that we're going to achieve those outcomes down the line. So the next session, I will describe some tools, strategies, approaches, and capacities and structures that I think need to be built in order to achieve that end. So now we can focus we can open up for discussion. You're free to ask any questions, but what I would like for you to do is to really articulate what your equity approach is now, and what insights, if any, have you gained about how you, your team, your agency, and your networks address equity? And what is your prognosis for success in achieving equity? And then finally, how and when will you know if you're doing all of the right things for everybody that's going to result in equity? So I just sort of like to lay that foundation for discussion, and then we can open up the floor for discussion.
Thank you, Dr. Hogan, for your wonderful presentation. You took us through a lot of really important things to consider in our equity work, in terms of like deconstructing what we're actually doing in practice, and then really the importance of taking a step back to look at the big picture of, you know, what are we doing? Is it actually having any impact? And what can we do differently? What can we innovate and think more creatively about in order to be more impactful in our efforts? We do have a few questions in the question and answer box, and just so the audience knows, I did open up the chat box too. So if you have questions, comments, or anything that you'd like to add as well, you can use the chat function now. And so I'll just go ahead and get us started with the questions in the Q&A box. Let's see. Someone would like some examples or specifics you might have on quote, rarely going deep enough to make a dent. Can you provide some examples on that?
Say it again, sorry.
Do you have examples or specifics of rarely going deep enough to make a dent in, you know, public health equity work?
Right. So again, this is something I'll talk about in much more detail in the next session, but one example might be how we do community engagement. And again, I'm talking the worst case scenario. There are people all along the spectrum, so this doesn't necessarily describe everybody. But when we do community engagement, many of us do sort of the bare minimum. We might, you know, assemble people that we pulled from the community, bring them to the table, usually at a time when we've already made 80% of the decisions, and then ask them to give their opinion on that. And we don't necessarily create the environment where the community can come up with their own ideas and present their own ideas about what needs to be done and how it needs to be done, etc. So just sort of the timing of when we bring community to that table tends to dilute the impact of what community engagement is supposed to do. So that's one example. And there are others. Again, I mentioned before how we do place-based work. You know, if we focus on that lower end of the spectrum, we constantly define interventions that we do in-house, and then we take it and place it in a community. That's the lowest caliber of place-based intervention. At the other end, which is the reason for doing place-based work, is to make sure that you're paying attention to context, all of the interacting and intersecting forces, that community is defining the ways of doing it right so that it doesn't create more stresses within the community or within their households, et cetera. So those are just two examples.
Thank you, Dr. Hogan. That you are exactly right. We couldn't agree more in that centering that community voice and community expertise, and how just purely impactful that can be in true equity work. There was another question about trainings. It says, is there any research showing that follow-up trainings to implicit bias awareness, such as managing unconscious bias, taking action to rewrite the unconscious script, has an effect on behavioral or policy change?
Yeah, so I haven't seen any research specific to that. So let me just sort of clarify. So if you think about our approach to public health and our understanding that behaviors exist within a context. And, you know, when we think about communities, we think about social context. So we want people to eat healthy. You have to make sure they have access to healthy foods in their community. The same thing applies to something like implicit bias. This is an individual behavior. And so that exists within a context. So to what extent is that context allowing those implicit biases to play out and to impact populations? So, you know, I'm not sure the extent that these levels of implicit bias training go beyond the individual behavior to the institutional behavior that monitors and provides incentives or disincentives to that sort of behavior, because that's what you need to really make a difference. If it's just behavioral change, it's only going to last as long as the institution supports that behavioral change. And so that means that it's not just the individual that has to change, but the context of that individual, which is the organization, has to also change to support those behaviors over the long term. Because otherwise, you know, we could take a whole agency, train everybody in the most intensive implicit bias possible. But what happens when those people leave and go work someplace else and you import other people into those jobs? Then what? If the structure doesn't remain after the champions leave, then you're not doing the work. You're doing a program or an intervention that's not permanent and that's not sustained.
Wow, thank you. We have another question. How do you view reparations as one vehicle to help undo the effects of historical racism?
It's absolutely a vehicle. It's, you know, they're one and the same. The question and the challenge is to define what it means. What does reparations mean, and how do you do it? Where do you do it? When do you do it? Who do you do it for? So, you know, reparations can take any number of forms, and I'm happy that it's gone from being sort of a banned word to something that we can actually say in public and have open conversations about and debates about. But we really need to push that science a little bit further. So it could range from any number of levels to, let's say, we understand that Black babies are more likely to be born premature. Premature babies are more likely to be ill, which means they tend to miss school a lot and they might have learning disabilities, et cetera. So what do you do to repair that? Because that's something that happened in the past, but that's going to continue to affect those babies into the future. What do we do to repair the damage that happened by them being born premature? Is it a nutritional solution? Possibly. Is it an educational solution? Possibly. Is it something else? Those are the types of things that we have to think about, and that's just one level. When it comes to the social issues, that's a whole other conversation and a whole nother science that needs to be developed about how we undo the damage that has been done in the past. And some of it has to do with making sure that that you sort of level the playing field. And that's what reparations are for, to level the playing field so that people aren't constantly working at that historic disadvantage. And that's a science that I think we need more energy and more intellect put into to really know exactly how to do that. And I think it's also something that communities can help to find what they need to catch up, to undo the damage of the past, to level the playing field. So that needs to be part of our conversations with community and our engagement with communities.
Thank you. We have another question that says, can you speak to the importance of those of us who are fighting for equity within systems to create support systems, given the level of resistance they face and the costs they will endure within organizations?
Yeah, that's a tough one. And that's one of the problems with the sort of DEI approach. You assign one person or a group of people who are the equity people and expect them to do all the work. And, we don't resource them well enough. We don't give them power, don't give them respect that they need to get the work done. So that's the first thing. We have to not make it a project, but make it an organizational issue. How you do that really depends on the organization. And sometimes, like in the case of our group at CDC, it was sort of this sort of dissemination effect. More and more people got drawn into that work group and into that circle. It infiltrated in other divisions within CDC. And the culture slowly begins to change. More research is generated. And over time, in this case, 30 years time, unfortunately, things change. But we can do it a lot faster by really pushing within our organizations to make the efforts organization-wide. And I realize that some people don't have the power to change what their organization does, but the funders do. And so this is why I say it's not just the organizations, it's also the funders who support those organizations. So whether that's Title V or Kellogg or Robert Wood Johnson or whoever, they as funders have the ability to say, this needs to be an organization-wide effort, not just one group. You need to adequately resource those efforts because we're going to adequately resource those efforts. So this is something that it requires change at every level on the spectrum, from the funders to the people working on the ground. But, if you're a small group within a larger organization and you don't have the power to change that organization, the funders do, and they need to start exerting some of that power, just like we did to get community engagement, a standard part of most grants, just as we did to get people to start thinking about equity a little bit more. The funders have the power to move how organizations function, and they need to use that power a lot more and be more discerning about what's authentic versus what's just written on paper.
You're absolutely right, Dr. Hogan. We have another question in the Q&A. It says, are there any communities that have engaged and organized in a way that they are collectively advocating for the change the community needs to be vibrant for all of its residents?
I think there are probably small examples of that, scattered here and there. How do I put this? So this is something that there has to be a pressure point. So the work has to start somewhere and then, infiltrate out to incorporate the whole community. So if there's one group, for example, that's doing work in a community and they're working in health, but the people in education and police and criminal justice and all of the other sectors are not doing the work, but they're affecting the same population, the impact is going to be limited. So this process speeds up the more the work is being done across all of the sectors that impact on a particular population. And so a lot of the sort of mind shifting that we need to do is to stop thinking we have to do everything ourselves and to really begin to think about how do we work with other sectors to incorporate equity into the work that they do, to make sure we have structures within our community to make sure everybody has the capacity across all the organizations so that we can then begin to build these structures for equity and these processes to support equity as a community as a whole and not just each individual agency. So that takes some mind shift to move away from everybody for themselves, each organization working independently to develop some sort of equity strategy to something that's a little bit more collective. And someone mentioned it sounds like a collective impact process, and that's exactly what it is.
Yes, absolutely. Public health didn't create disparities by ourselves, so we can't eliminate them by ourselves, right? So that was actually the last open question that we had in the Q&A. If there's anybody else who would like to ask a question to Dr. Hogan, please feel free to use the chat box or the Q&A box. But in the meantime, I would just like to reiterate that Dr. Hogan will be presenting a part 2 to today's talk. So today she took us through a deconstruction of current common equity approaches in organizations. And then in May, she'll take us through a journey of reconstructing what we could do better, what we could do differently. And it is tentatively set for sometime during the week of May 17th. We're looking at May 19th. I just have 1 or 2 hurdles to clear before I can officially set that date in stone, but I will send out a follow-up email after this with the recording and Dr. Hogan's slides, and then a registration link for the part 2 to Dr. Hogan's series.
If we still have a little bit of time left, it'd be helpful to have people respond to the questions that we pose, like how do you articulate your equity approach? And what insights, if any, have you gained about your approach? And how do you sort of predict what kind of success you're going to have in the future? And how do you know that? It would be helpful to have some discussion around that. I'd love to hear from you all.
And there was a comment in the chat that says we are looking to work with Woke Coach or GARE or publichealthawakes.org. Are you familiar with any of those organizations?
I know GARE, I don't know Woke Coach. And so say a little bit more about that. So is it capacity development? Is it training? What exactly will they be doing? And to what end are you hoping, what are you hoping that's going to help you to do?
And Sharonda, if you are open to it, I can make it so that you can talk and you can just have a conversation with Dr. Hogan as opposed to having to type it all out in the chat. I'm not sure. There we go. So if you want to unmute, you can. Yeah. Hi, Sharonda.
Hi, how's it going?
Good.
Can you hear me?
Yes, we can hear
Okay,
you.
perfect. Okay, so one of the things that we're looking at is kind of doing what we are considering like a two-prong approach. So we're trying to internally change the culture within ODH, which we're calling like a conscious awareness campaign, and that really would be like the woke coach aspect. And then the other entity is one in which they're very process driven. So they're more like strategic plans and how you can organize all your programs in a long term. They both do independent consulting. So that's what we were trying to see if you had heard anything about either one of those, or even if you're familiar with GARE, that was also another option that we're looking into.
Yeah, the GARE is the only one of those three that I'm familiar with. And I do know that they do specifically capacity building around looking at your own organizational processes and policies, procedures, et cetera, to make sure that they're always promoting equity. And that is a type of structural change that needs to happen to be able to move equity to unfold. And again, but it can't stop with just your organization. You need to influence your partners and networks to go through that same process.
Sure. Okay, perfect. Thank you so much for that.
Let's see, we have somebody who focuses on implementing a DEI or racial equity initiative throughout an organization that includes finances, funding, community engagement, hiring, vendors, partnerships, compensations, and that sort of thing. Which, yeah.
And that's perfect. I mean, that again is the beginning of structural change within the organization. So if you're not rewarding people for working through an equity lens and disincentivizing people to work through implicit biases or racism or whatever, then you're not going to create change. It's got to be factored into your organizational processes. So that's a great step in the right direction. And that's something that involves the entire organization and not just one team. But the importance of funding, appropriate funding for equity work is really critical, because if you're not providing adequate funding for something, then you can't go deep. You can't get at the meat of the problem. And so reorganizing your priorities to make sure that the equity work is seen as part of public health work. The success of public health depends on achieving equity. So it has to be adequately funded. And so this is something that everybody from the funders to Title V agencies to any of the contractors that work with us, with you, have to appropriately budget for equity activities to the level of the complexity that exists, and not just, the basic sort of, we're going to do a training and the training costs $5,000 and then we're done. That you have to move beyond that.
Yes, thank you. And there was another comment in the chat that says, my equity approach is to invest in community leaders and strengthen local BIPOC-led organizations, and then connect them to a national network.
Okay, so one of the reasons why I sent out that sort of matrix for some of the Title V agencies, I think filled it out. And you all will have it when you have the slideshows. In fact, I think it went out to everybody. I'm not sure about that, but it's important to look at those items and see how you would classify yourselves. Which of those things are you doing? Because in reality, you should be doing most of them and some other things. So if you know, like I said, doing all of the right things and doing all of them right for everybody is important. And so this activity is really critical. And I'm going to talk about that a little bit more in the next session, that, you know, community engagement is sort of the linchpin of getting equity right. And so we have to get the community engagement part right. And so if I had all the money in the world and I could invest in anything, the first thing I would do was to do exactly what you're doing, is making sure communities are organized, that they're learning, that they're doing their own investigation to find out all the challenges of everybody in their community, so that they do exactly what we do as public health workers. When we go to a table to consult, we do our homework, we do some research, we talk to colleagues, we do some reading. We need to create spaces for communities to do that same thing, so that when they come to the table, they really are an equal partner and they have ideas of their own that reflect their values and needs and resources and culture, et cetera. And it's much easier to bring those two pieces together when that happens. What usually happens, I think, is communities come to the table and we spend all the time presenting what we wanted to do, and they get to react to that and not necessarily have the ability to create something from scratch. So I think investing in community learning so that they become much stronger partners when they come to the table is probably the best investment that you can make as a first step. So I commend you for that. But it's not all you need to do. There's plenty more after that, but that's a great start.
Thank you, Dr. Hogan. We received a comment that says, in Northwest Ohio, we are implementing the Pathways Community Hub model. And several years ago, our community publicly prioritized addressing racism as a social determinant of health. We have worked with housing and transportation providers to prioritize housing and transportation for pregnant women who are primarily African American with high risk for poor birth outcomes and infant mortality, and providing support through community health workers throughout the process.
Okay. So what are you building? You just described what you're doing. What are you building?
Let me see. Okay, so this last comment was submitted by Jan. Jan, if you're still on, I'm going to promote you so that you can unmute yourself and then have a conversation with Dr. Hogan.
Hi, this is Jan Ruma from the Northwest Ohio Pathways Hub. And I think what we're doing is trying to build a community with families that have stable homes and places to live and access to transportation and a support system through a community health worker that helps them with transportation and all of their other needs. Really, you know, what we found over the years is we have a lot of people who needed housing, were in really unstable environments, and the system wasn't set up to help them get connected. And so we worked with those systems to designate housing choice vouchers and put our clients first in line to jump through all the government hoops to get connected to those resources so they can have the opportunity to get housing and such. So just really, I think our approach has been just working to have the systems aligned to be more accessible to the people who need whatever resources they may provide, that before that they just weren't able to get connected because there were so many barriers. I mean, just fill out a housing application for HUD, you need more information than any one person would have. And so by kind of dissecting that process and then training community health workers to help their clients, you know, really jump through all those hoops, we're resulting in people having a stable living environment, which we think is a foundation to have a healthy baby and be a, achieve your goals.
Mhm. So is it possible to get rid of the hoops?
So far, we haven't figured out how to get rid of the hoops. We've just learned how to systematize the hoops, because many of them come from the federal level in terms of HUD requirements and those kind of things. And then many of the hoops when it comes to transportation are financial. For a monthly bus pass in Toledo, Ohio, an unlimited bus pass is $60 a month. Well, if you don't have that, you're going to just pick and choose which trips you take. And so we worked with funders and the Transportation Authority to make it possible for pregnant women to have an unlimited bus pass. And so I guess in that way we got rid of that barrier. But I think so many of the hoops are systematic and designed to make it easier for the system to process and track, but really are disconnected from the people who need to rely on the system.
Right. So remember something I said about there are necessary and sufficient things, and there are things that are necessary but insufficient by themselves. With equity, there are lots of things that are necessary, and all of them together are sufficient to achieve equity, and you can't just do one and expect equity to unfold. So wherever you have facility to act, which in your case is in this housing and transportation realm, that's a great place to start. But you have to have in mind where that piece fits in the bigger picture of disparity causation. So what are the other components that need to also be addressed to make sure that you're addressing that full spectrum of risk, exposure, past, present, future, et cetera. And so that's what I'm trying to get everybody to start thinking about. Again, I don't want anybody to think that I'm being critical of what you're doing, but our outcomes speak for themselves. We're not getting where we need to get, and we haven't for many years. And there's no way to think that if we continue to do the same things that we've been doing, that we're going to get there. So we really have to step back and think about the bigger picture. What is it we're building towards? Are we going to keep chasing, some problem over the years? And it's just the one problem, but there are 16 others that have to be addressed to achieve equity? Or are we going to step back, look at the bigger picture, do the piece we can do, but make sure our partners are doing the pieces they can do, so that we're addressing the full spectrum of what people need to achieve equity, what communities need to achieve equity. So again, no criticism about what anybody is doing. I think, people are doing the best that they can with the resources that they have, but we've got to do better. We've got to do it differently. And that is from the funders level to the Title V level. Again, all of us need to do something a little bit differently. And hopefully when we finish the next session, you'll have a better sense of what I would propose we can do to make that happen, and translate the pieces that you're doing into a more holistic picture of how we can achieve equity.
Okay, Dr. Hogan, thank you for responding to that. So we are at 5 past the hour, and I know that we promised we'd finish at the top of the hour. We have some additional comments in the chat. Would you like to keep going, or would you like me to send them to you and we can work to address them afterwards if there are questions?
I don't want to hold everybody up, and I actually do have another appointment, but if we can save the questions, then in the next session, maybe we can address them.
Perfect. I think they might go well for that reconstruction topic of that next section anyway. So thank you for taking the time to be with us today. And thank you everyone who's still on the line. Please look forward to an email from me with Dr. Hogan's slides, this recording, and registration information for the next couple of webinars, which does include the part 2 to Dr. Hogan's series. And again, I'll save the chat, save the questions and anything, and then we'll look forward to addressing them in the next session. All right. Thank you, everybody. Have a great afternoon.
Thank you.